Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Tyler Evans. He's an infectious disease physician. Today's Kevin MD article is Meeting Transgender Patients Where They Are, a Healthcare Imperative. Tyler, welcome to the show.
Thanks, Kevin. Good to be here.
All right, let's start by briefly sharing your story and then jumping right into the Kevin MD article that you shared with us today.
I'm a adult infectious disease and addiction medicine doc. I've worked with trans folks for the last sort of dozen years or so. I am deeply committed to the mission. I've worked in for many years in the global south, low and middle income countries, areas in like sub-Saharan Africa, Middle East, Latin America. I've worked in war zones, complex humanitarian emergencies. I've worked on the Ebola response twice. And I guess, throughout all those experiences, I sort of connected that to my work in the US and a lot of my work in the States. A lot of the sort of foxholes of the sort of chronic health inequities, places like the South Bronx, South LA. I have a theory on the Souths, connecting that to sort of the South Sudan experience where I was the only doc for 29,000 refugees. And I didn't see that much difference really in terms of the sort of the feeders that connected to the healthcare outcomes. So in terms of, I mean, the magnitude of the burden of disease was considerably different, but in terms of sort of the feeders, a lot of them were very sort of similar. And so that sort of universal sort of thread are often socially and politically driven. And so I talk about that extensively in my book, Pandemics, Poverty, and Politics. And so when I kind of focus on certain sort of communities, particularly historically marginalized communities, trans communities are a key one.
Mm-hmm.
That I guess sort of the good news is we've had a lot of advances in terms of the sort of understanding of what trans health looks like in the United States and beyond. And I've talked about this extensively across the country. We have really good sort of evidence to support, primary care, surgical care for trans communities. Unfortunately, we've gone several steps back in the last few years as a result of the politics and us sort of focusing on, the sort of the wrong messages and sort of, banning particularly pediatric sort of care for trans communities. And it's so important to get it right early on. The evidence is very strong for that case. If we are able to provide gender affirming care at a very early age, the outcomes are very sort of similar to cis sort of communities in terms from a mental health outcome. So it's really important to get it right early on.
All right, so you talk more about these issues in your Kevin MD article, Meeting Transgender Patients Where They Are, a Healthcare Imperative. For those who didn't get a chance to read your article, just tell us what it's about.
It's essentially, it's just sort of summarizing the importance of understanding the sort of the trans experience and providing that gender affirming care. Essentially coming at it from a trauma informed perspective as much as possible, and honestly, not really sort of treating trans communities any sort of substantially different than you would any sort of patient. You just meet them where they're at, and then you understand where they are in their sort of experience. I think when we look at sort of trans communities, the simplest way that I sort of explain it is there's sort of three sort of chapters to their path, right? The first is sort of the realization, connecting to that sort of identity. That's a big one, right? I don't think we often sort of acknowledge that. And so when we have certain patients that might identify, with different sort of gender pronouns, and we might see a sort of a beard or some other sort of physical manifestation, and we're hearing sort of a feminine name. Sometimes as docs or providers, we see that, and that sort of that sort of disrupts us, right? It disconnects to everything that we've ever been sort of trained to sort of understand. And it's really important to just sort of let go and just understand where they're at, and just sort of meet them where they are, even though it sort of deviates from our sort of cultural norms or understandings. The second is really just that the primary care modalities are not significantly different from what we do in sort of general practice. Yes, when it comes to certain sort of prevention modalities, cancer prevention, et cetera, you've got to follow the guidelines in terms of their sort of, their biological assignment at birth, et cetera. So you got to kind of sort of get used to that. Then there's the hormone sort of component, and you really need to understand what's important to them, right? And I think that doesn't really deviate much from that sort of that physician or provider patient relationship, right? It's really important to understand, what's important to our patients and to sort of get them there. And then the third is the surgical, if they choose to accept that. And there's a few other sort of pieces in there. There are some behavioral health concerns sometimes that we do need to sort of address. it's hard to live in that space, right? Particularly in today's world when there are so many politics and making these folks really feeling uncomfortable, particularly as kids. Even in my own community, I live in Santa Cruz, California, which is generally a pretty sort of progressive community. I sort of go back and forth between New York City and Santa Cruz, both very progressive places. And yet, even in my own community, there was a school where my youngest son was at, a Montessori school. He was 2 years old at the time, and not trans or sort of deviated from the sort of the biological course as far as we know. And the school essentially started banning books that were sort of talking about it and whatnot, and that made us sort of feel very uncomfortable. So we're seeing it all across the world, and I can only imagine what sort of certain parents are experiencing. So I think the really important thing as docs and providers to be champions for our communities and really help parents out as much as we possibly can.
So, as you know, a lot of physicians don't get a lot of education when it comes to treating trans patients. So, in the exam room, I'm a primary care physician. Tell us the type of questions that we should be asking that would kind of maintain that sensitivity and understand some of the lived experiences that trans patients are going through.
The most important ones are really just sort of understanding where they're at in their journey, right? So, start off with the gender pronouns. Sometimes that gets confusing for certain primary care providers. They're trying. I see this happen often. I see that they're trying, but it's a bit uncomfortable for them because it's something different, and that's okay. I think that cultural humility is really important to invoke into this sort of space, right? Like just sometimes, particularly in the beginning, I would just say, listen, I don't often do the gender pronouns. My name is Dr. Evans or Tyler. That's how you can address me. And, tell me about you. Tell me about, your experience.
Hmm.
Tell me about how you want me to talk to you. And if I make some mistakes, I really apologize. I don't mean to do it. That really works. If you're just human about it, I really feel like that just, level set, understanding kind of where where they are in the journey. Again, when did they first sort of identify as a gender sort of, different from what they were sort of assigned at birth? We are seeing a lot of gender fluidity, nowadays. So it's sometimes not just sort of this bifurcation or whatnot. And understand where they want to go, right? Like understand a lot of folks. I was in New York at the time where Medicaid was starting. Most of my patients are Medicaid. Almost all my patients are Medicaid patients or uninsured. And so when Medicaid started supporting the surgeries for my patients, I mean, they were queuing up to get there, but not everybody is. So, you really just have to see sort of where they're at. And the primary care piece is really, really important. Again, the primary care should not be that different. And I honestly think that as physician champions of these communities, I think sometimes we did a little bit too much about treating these folks differently,
Hmm.
right? Don't treat them differently. They're just humans, and their care is slightly different. But just again, primary care sort of approach is very similar. And then there's the other pieces. There's that are sort of you know, sort of peripheral to the, well, it's not peripheral. I mean, they're just sort of adjacent to it, which is, the hormone modalities. A lot of my patients didn't want hormones and sort of, ask them, what is this sort of the outcome that you want? And if it is, then the primary care providers can easily look up what the guidelines are.
Hmm.
There's tons of CMEs out there that they can sort of receive. WPATH is the gold standard for trans professionals. It's the World Professional Association of Transgender. I forgot what the H stands for, but go to WPATH. There's guidelines out there. UCSF has great guidelines. They're out there. Get your CMEs, learn about it. It's really important to your patients.
So, on the other end of the spectrum, are there any red flags or things physicians definitely should not do that you're seeing that they're doing?
You definitely don't. I mean, obviously, you don't want to disrespect your patients, right? You need to, if you do sort of slip and say certain things that sort of triggers them, you have to understand why it triggers them, right? They're dealing with decades of trauma, and so it's not you. It is just it's you just happen to trigger them. Getting back to that cultural humility, apologize.
Hmm.
Just apologize and just say, hey, I really apologize for triggering that. I can understand how, use that sort of empathic language that we have, been sort of trained and experienced to sort of, invoke here, and just say, hey, I can understand, how this, triggered you. I'd like to kind of get back on track, et cetera, et cetera. Don't go rogue, right? You got to get some training. Yes, it's not that difficult, but don't go rogue on this stuff. Phone a friend if there's something that's
Mhm.
a little bit different. What we do often find are some of our patients may actually back in the day, it's changed considerably, but back in the day, 15 years ago or so, a lot of my patients would get hormone meds on the streets, right? Because there weren't a lot of providers out there that could get it. And so some of those meds were expired or not sort of good or not real. And sometimes we'd see sort of excess amounts of certain medications. So, spironolactone is sort of one of them. So you want to sort of, measure, your potassium, for example. So you just got to keep on track on certain things. Don't go rogue. Understand that sometimes when they're taking something, there's this sort of rush that folks are feeling. Imagine, right? It's hormonal. So when they're feeling that rush, whether it's the sort of the testosterone or the estrogen, they might use too much of it. And so you really have to sort of track that. And if they do deviate, and I've seen this quite a bit, you just have to level set with them. Just say, hey, like this isn't working. I understand that it's really important to you and you want to accelerate it, right? Like imagine these folks are
Mhm.
like they now have access and they're feeling the rush and they just want to move on that journey. And you gotta pump the brakes. You gotta slow it down. And we have to do this together because there are serious consequences, if you kind of go too fast.
So you mentioned politics, of course, a few times. Just give us a sense of some of the lived experiences that your trans patients are currently feeling or living through under this political climate.
Yeah, it's rough. It's California, New York, your kind of core sort of blue states. It's a little bit easier for our patients, but even there, it's hard. I mean, I hear a lot of narratives from our patients that, in particularly in other states where they're thrown every types of sort of verbal assault. They've been beaten. There was one particular situation where I had one patient, he switched to us because that person was sort of incorrect, was provided the incorrect name at the front office, and somebody knew that person and followed that person home and beat them
Mm.
because understood that they had transitioned, and that was not okay. This is in the Bronx. So they are going through a lot in terms of the sort of social environments that certain communities don't understand, and then in terms of the politics, I mean, we are not in a politically supportive environment right now, unfortunately, and unfortunately, a lot of folks don't understand the science, right? Almost every sort of academy or institution, the American Academy of Pediatrics, the American Academy of Family Practice, certainly the WPATH and WHO. There are so many institutions, almost every one that I know of, ACOG, that supports gender affirming care. The science is there, it's real. There is a pathological element to it, and that's tough sometimes, right? So we have to, when we are, I know it's deviated slightly from your question, but this is important.
Mhm.
When we are communicating this to the patients, sometimes this comes up. Why are you treating me like this is a disease? This is not a disease.
Mhm.
Here's the problem as docs. We have to, right? We have to code it that way, right? We have to put in an ICD code in order to basically get our care sort of reimbursed. That's the reality of medicine. And so I think it's important to frame it that it's not a disease per se, it's just a state of health, right?
Yeah.
And so, they might see that on their paperwork, and we have to just sort of explain that to them. I and others have worked for CMS to sort of change some of these ICD codes and whatnot. It's an uphill battle. So there's a lot of politics against this. I'm an optimist. I do think we will get past a lot of these sort of challenges, and I think in the future, I think that we will get to a better place. But at the same time, I am a member of communities. I'm a dad of four. I understand how communities can react to this, and they're scared about their kids as well. They're scared because they don't have the information. That's it, right? Bottom line, a
Mhm.
lot of these folks just don't have the information. Beyond that, their politics or whatnot, we can't change that. But I think that as docs, as champions of these communities, if we can explain this in a way that really gets to the core elements of people's sort of moral compass or ethical base. Even a lot of sort of religious communities, particularly Christian communities, I have certain, good friends who have experienced this themselves or have fathered or mothered, children that are going through this experience and who are religious. And so, and it's been transformative for them. So if we can really explain this to people to understand what these folks are going through, I think we can get to a better place. But we can't push these folks either, right? We
Hmm.
can't. I think that was some of the problems with our space about, in the last 10 years or so. I think we pushed a little bit too fast. And I think from a political spectrum, in terms of like the 2020 election and whatnot, I think we were just pushing too much. And I think we need to go at a pace that is commensurate with sort of, what people are comfortable with. And I think we just have to read the room there.
And what does that mean? Like when you say that you have to go at a pace that are commensurate with people's comfort levels, what does that mean to you?
Well, you have to read the room. If you are in a California coastal community, then you have to kind of see where folks are at. I mean, if you really are a local leader, you have to understand. You got to talk to folks and just sort of ask them questions and sort of see where they're at. You have to talk to community leaders. You have to talk to interfaith leaders. You have to talk to other CBOs and see where those folks are at. And then again, you need to sort of just go at a pace where you feel like they're going to be sort of comfortable with that. I'm generalizing here, but if you're looking at sort of like a very conservative state, perhaps I'll just throw out a Mississippi or a Kentucky or an Indiana or something. That's going to be a very different pace from a sort of California. I think they'll get there, perhaps, right? Or certain sort of micro communities will. But again, you have to explain it, and you have to get the right stakeholders in the room to sort of get them there as well. And interfaith leaders are a big one.
So we're going to look at a situation perhaps where different states are going to have different levels and different comfort levels with gender affirming care.
Yeah. And I mean, as a doc, I mean, I always, use sort of metaphors to what we are doing. It's, you got to triage, right? You got to see where folks are at and how you can get them to where you want them to go. And, you got to use your sort of population health scalpel to do, and you might not be able to do everything, but you could probably move the needle to sort of get somewhere. So that's important to acknowledge.
So before we summarize, just tell us in your ideal world, what would your ideal vision be like for gender affirming care if you were in charge of everything? What would you like to see happen?
Great question. I would love to see a place where all providers had some training on this, and there were general grand rounds or conferences around this where there was sort of dialogue, interdisciplinary sort of rounds and sort of dialogues to basically help address certain sort of patients. We could look at certain sort of case studies, et cetera. I think if all medical communities needed to sort of come together to understand the intersectionality of these humans and how everything comes together, and we all learned from that and sort of looked at the science, I think we could really have some considerable sort of advancements in sort of biomedicine. I do think there has been considerable research. If you go to the last WPATH conference I went to was about 9 years ago. I actually piggybacked my marriage, my wedding on that. It was in Buenos Aires, Argentina. I ended up getting married in Argentina. But at that time, I had looked at there was one session where they were looking at the increase in studies on transgender and gender affirming care. And it was almost a sort of parabolic curve, it was really considerable. So, I'd love to kind of look at where that's at now. Unfortunately, I think it's been a bit stagnant in the last few years, again, because of the politics. But again, I think we'll sort of get back there. And I think if we use the science, the evidence to support this care, I feel like most docs, not all, but most docs and healthcare professionals would sort of, support it.
We're talking to Tyler Evans. He's an infectious disease physician. Today's Kevin MD article is Meeting Transgender Patients Where They Are, a Healthcare Imperative. Tyler, let's end with some take-home messages to the Kevin MD audience, and certainly you could mention your new book in that as well.
Great. Thanks, Kevin. So, the take-home messages again are, my practice in healthcare, both on the individual level as well as the systems level. And, lately now I run an organization called Wellness Equity Alliance. And so we are working in the streets through street medicine, HIV street medicine mostly. We are working with at-risk youth. We're working with carceral health communities. We're really focused on historically marginalized communities because we're looking to sort of close the gap on those inequities. So I often now, treat the system as opposed to sort of the individual, but I still do see patients and the system's very sick.
Hmm.
And, the reality is, I think we need to understand that more. And I think that as our students come out of their training, it's really important to understand how the systems connect to the individual sort of level. And I don't think that we get enough of that in medical school. I think when we can sort of marry the med school with the MPH, for example, or public policy, you start to understand the sort of the more macro. And I think that's really important to really understand the systems that you are working in before you sort of just apply your technical skills to that. And a good example, a concrete example of that is in my world, we address a lot of our issues through the syndemic lens, right? So that's epidemics, not necessarily infectious in nature, but the syndemic lens, which are epidemics that are sort of working together synergistically to amplify the outcome. So HIV, for example, never really acts alone, right? I cannot, in the individual exam room or on a systems level, we cannot look at HIV in a vacuum, right? We need to understand how it sort of intersects with behavioral health, with addiction, substance use, with other infectious diseases, and particularly with the social determinants. So that is the main takeaway message, to really understand how health is all sort of connected, and particularly when we're looking at historically marginalized communities, we need to understand that all of these pieces connect. And if we are not addressing all of that, you're going to lose. So it's super important to do that. I talk a lot about that in my book, Pandemics, Poverty, and Politics. It's on Amazon, Barnes& and Noble, published by Johns Hopkins University Press.
Tyler, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Great to be here. Thanks.